hit the record button. Wonderful. Thank you all for being here today. On behalf of the steering committee, led by John Kelly and myself, I'm welcoming you back to our Recover Seminar series after a summer break. We're excited to be back and we're excited to have you with us. Today, we're going to be talking about data. Before I get there, I want to get through some of our usual opening slides. So if you want to go on to the next one for us. Here we go. As you know, the overall goal of this whole project, it's a 5-year project, and we're actually beyond the halfway point at this point. Our goal is to advance the science on recovery community centers. And we want to do this by bringing together all the different stakeholder groups to whom it's relevant and who have insight and guidance and the stake in this. And we want to bring them together in this seminar for discussion and to learn from each other and to build consensus around issues, to highlight issues that are important and so forth. So I appreciate each one of you for being here, and we encourage you all to share your experiences and thoughts with us as we go. This is sort of who we have as our typical breakdown for the different stakeholder groups that are represented in our seminars. And in a moment, we'll ask you to tell us who you are so we can update this pie chart as we go along. If we can go to the next slide. As you also know, is that we are funded by the National Institute on Drug Abuse, and alongside our project, which focuses on recovery community centers, they've also funded other projects that look at recovery support services. And we have all formed together a consortium on addiction recovery science. And we put the link up there for you in case you want to know what the other groups are doing and where you might have intersectionalities, where you want to reach out to some of their programs. On this slide, we are highlighting some upcoming activities and deadlines that might be of interest to you. And then if you see something on the website overall and you want some further feedback, we are also very happy to chat with you about what the other teams are doing and introduce you to folks and so forth. So here we want to highlight that for our program, we have an October 1st deadline, not October 5th like I thought a moment ago. We have an October 1st deadline for our last cycle of pilot study funding on recovery community centers. So we have a link here if you want to see what you need to put together for the letter of intent, which is due on October 1st. The long application is due later, but the first letter of intent is due on October 1st. A very similar thing, it's for a pilot study program, is on recovery housing. That deadline for the letter of intent is November 13th. It's also, now the materials are online if you want to check those out. And then we list here some work groups and seminars, but I won't go into too much detail in now, just to say that they are on the slide, and after this meeting on Monday, probably, you will get the usual email from us all, which will contain these slides, so you can actually click the links, as well as a link to the recording of the seminar, so you can view it at your leisure as well. But these resources exist. I hope you take advantage of them, and we're always happy to make connections for you. Next slide, please. All right. And of course, since we are talking about recovery community centers, what we always like to do is have a live feature to start us out, to ground us in what are we actually talking about. And we've also learned that recovery community centers are all different. There's no two alike. Today, we have with us Oliver Birchwood-Glover, who is the program director of a Trilogy Recovery Community Center. And he's going to tell us what happens when you walk through the door of his RCC. Oliver, over to you.
Good morning. Thank you for the invitation and the opportunity to speak with you all. So Trilogy Recovery Community is a grassroots peer-led organization that began about 12 years ago. We initially focused on teens at risk, and while frequently substance use was involved, there were a range of social emotional challenges that the kids were dealing with, including legal involvement. And over the years, we've come to include the adults as well. So we do quite a bit of outreach. We do a lot of work at the schools. We have a large geographic region, but we're a very, very small agency with 2 recovery coaches and 2 mental health individuals, and then also a recovery navigator on site, where we have a full-time student assistance services program. So we're pretty small. One of the things that I love about our agency is that everybody sits at the front desk to greet people, and everybody takes out the trash. There's very little hierarchy within the agency. And when we talk about a recovery community, that's really how it is. I talk with staff about we have to think of ourselves as a village and as a therapeutic village for each other, for each other as well as the individuals coming in. So you might see me at the front desk. You might also see a 17-year-old individual who is on a learning how to work internship at our front desk. You might see retirees sitting at our front desk. You might also see one of our recovery coaches or one of our student interns in a graduate program. And so everyone's welcomed and brought into the agency. It's a small office with long hallways and rooms, but we've worked very hard to make it a welcoming environment for everyone. So we offer to the community 7 recovery and mutual support groups, some with mental health as well as substance use themes. But we do that as a community service at no charge to anyone participating. So we have direct service for enrolled individuals, both teens and adults and family members. And then we have our community service groups. And we do a lot of, psycho-ed interventions at the schools. So do I have more time, Bettina, or?
I think that was probably, if you want to add a closing thought, that's totally okay, but I think you're doing great.
Yeah, I think, we were talking about RDP. I think RDP has been an interesting experience for us. But am I jumping the gun?
Yeah, we first want to let them talk about the RDP and then react to it.
Okay. All right.
So we'll do that in the later part. But thank you, Oliver.
Thank you.
And I love the quote that you had about everybody gets to the desk to greet and everybody has an equal chance of bringing out the trash, a community part of it. That's wonderful. Thank you.
Yeah.
All right, moving on to the next slide. As I mentioned, we always do a poll to kind of capture who's in the room so we can update our pie chart. And then in this poll, we also usually include some questions about the actual quote-unquote main event. Today, our topic is the Recovery Digital Platform and data collection for recovery community centers. So you will see questions on that as well. If you can go ahead and start the poll now, Olivia. Here we go. So you just click through it. There's a little gray thing at the side that you have to drag down to get all the way to the bottom. And then once you have answered every question, you just hit the submit button and then you're all set. So I'm going to do mine too. And if you have questions, just say out loud in chat and we can help guide. And you'll notice that for some of these questions, we say other, and please put your thoughts into the Zoom chat. If you do, that's great because we actually look at all the Zoom chats in the end, like after the meetings, and highlight notes that we want to use for food for thought for the next seminars and future directions and so forth. And of course, everybody else can see it too. So please do use that functionality if you feel comfortable doing so.
Are these anonymous? Are they?
I didn't quite hear the question.
Are these polls anonymous or names?
Anonymous?
Yeah,
they are anonymous. Oh, thank you, Trevor, for putting that comment. How are we doing, Olivia, for completion?
We're at 75%.
All right.
Okay, we just did 80.
Oh, 80, perfect. Let's end at 80. That's perfect. Unless anybody wants to still complete.
Oh, I
21.
did it already.
Ah, never mind. That's all me. All good. All right, what do we have? We can share. We can show results to everybody. Okay, so John and Phil, these are going to be interesting to you to kind of see the data questions here. I'm going to jump right down to them. So we have some people who have other, which is great, and put it into the chat. So just about everybody in the room think that data provide evidence, which is important to increase funding and updates to policies. So that's great. And that is something we want to keep in mind when we talk about how we're going to collect data and what we can get out of it. So I see lots of love for data here, which isn't surprising given the topic, but it's still wonderful to see. For what makes data collection difficult. And the biggest one here is that navigating data collection tools can just add stress and administrative burden. That's the biggest one here, which I think both John and Phil are going to be talking about as well. So they'll be addressing that one. We have less worry about what people might do with the data, which is great. There's a lot of trust in the system and knowing what's going to be done with the data. That's amazing. So I'd love to see that. And here we go. Does it get in the way of relationships? And most everybody thought that possibly, but not if we set it up well. And here, teaser for you all. At the end, we're going to ask you what can be done to make this work well. If you guys can share your personal experiences, that would be amazingly helpful. All right, and then for familiarity, you have some fans in the house, Phil and John. We have some people who are very familiar with the RDP, as well as people who are new to it. So you have a whole gambit, which is great. All right, if you can go to the next slide. To set the stage for our main event today, you guys might recall that we did conduct a nationwide survey of recovery community centers a while ago. We presented results in September and October of 2022, and those slides and recordings are, of course, available. And within that survey, we asked each RCC director, does your RCC currently have a standardized way to assess if and how clients or participants progress in their recovery or benefit from the services of your center or organization? And 69% said yes. So there's a lot of data collection that's already happening, and it's taking a number of different forms. And then there's also some for who they haven't been figuring out yet how they want to collect data. So I think it's an ideal way to start to turn it over to you, Phil and John. We can go to the next slide about how the RDP might help and why you designed it. So I'm very happy to introduce to you all Phil Rutherford, the Chief Operating Officer of Faces and Voices of Recovery, and of course, a steering committee member of this whole overall project to advance the science on RCCs, and John Picard, the IT Manager of Faces and Voices of Recovery. Over to you guys. Thank you so much for being here with us today.
Very good. Very good. Thanks a lot, Bettina. And I just want to I want to start with, you said something in the polling. It said that there were people familiar, and you said that we have fans. That's not a guarantee. I just want to point out that people may be familiar. That doesn't guarantee that they're fans, but I am hopeful.
Fair point.
I'm hopeful that they are fans, and hopefully we can. If they're not fans, we can convert them. So. As Bettina said, my name is Phil Rutherford. I'm the Chief Operating Officer here at Faces and Voices of Recovery. You're going to meet John Picard in a moment, not John Luke, John Picard. And we're here to talk about the Recovery Data Platform. Next slide, please. So I want to start with a few key principles, and I know that I'm probably preaching to the converted, in that if you're on this call, there's a good chance that you believe that recovery changes lives. We know that, we believe that. Many of us have seen recovery in action, and we've seen the way that it has the ability to change people's lives. We know that data is the supporting characteristic of that. We know that obviously stories have power, but a lot of times, if you're trying to look at aggregate stories, you need the data to support it. And we believe that RDP helps to inform the recovery movement through analytics. Next slide, please. And I know that I'm talking to a broad range of folks, so I just want to talk for a moment about analytics. I'm not going to nerd out and get into the weeds about analytics, but I just want to talk about a few different types of things. So we look at 4 different categories of analytics: descriptive analytics, that's just what happened. And that provides hindsight, kind of like looking back over your shoulder. Descriptive analytics tell us about a thing that happened. Why did it happen? That's a little bit more difficult thing to gather. Like we don't always know why. We can always prove correlation, but we have some insights into that. Those are called diagnostic analytics. When will it happen? Those are predictive analytics. Like it would be nice to be able to predict when a thing might happen. Like if we're looking at a return to use or something like that. And to be clear, we're not in the field of substance use disorder data analytics. We're not there. There are a few things biologically that people have done with wearable technology, where they've looked at changes in heart rate and a few other things to look at predictive analytics. And then ultimately, we want to get to prescriptive analytics, right? Like how do we make a thing happen, or how do we prevent a thing from happening? And that's sort of, if there is a North Star of analytics, it's prescriptive. Next slide, please. And one actually, before you go, I'm sorry, flip back one slide. If you look at this chart, and the axes in this chart are value and difficulty, you'll notice all the way to the right, difficulty, prescriptive analytics are the most difficult thing to collect, and that's ultimately where we want to go. Okay, next slide. So just a little history on RDP. We have been working on RDP at Faces and Voices actually since about 2016. And I'll try not to tell too many stories while we're talking, but one story that is pretty important in the development of RDP is that in 2015, the Surgeon General at the time was Vivek Murthy, which I think he's Surgeon General again, if I'm not mistaken, but it produced a report on addiction in the United States. It was a big purple book. It was the first of its kind. Everyone in the recovery space was super happy that we now had something in the public space around addiction. And that guide, or that report, had a number of chapters. One of the chapters was specifically on recovery. It was also the smallest chapter in that book, or the smallest section in that book. And at an event, I asked someone in that administration, I think when we were prepping for this call, I was saying that I wasn't important enough to talk to the Surgeon General at that time, but I was just like, hey, why isn't there that much information here about recovery? And they said that's because you have no data. And I was offended by that, because the thing is, I had been around to recovery community centers and recovery community organizations even a little bit, and I knew that there was data somewhere, but it was like trapped in spreadsheets or trapped on grids of paper that were in file cabinets. So I knew there was data, it just wasn't really properly arranged, and that kind of started the movement towards RDP. And we looked around as part of a work group with Faces and Voices, and we looked around for other software that would kind of meet our need. And unfortunately, we found it all to be pretty clinical and pretty much not what we wanted. So we decided to build something on our own. And this is how we got to RDP. And the idea of it is different than most pieces of software that you see, in that it is designed at its core to help the participant grow their recovery. So yes, it's about data aggregation. Yes, it has Salesforce underneath the hood, so it can scale to really big data. But at a core level, it can work for an individual to chart and track their own recovery. So it can go both big and little. Last year, the end of last year, beginning of this year, we started rolling out RDP 2.0, and John is going to talk to you about that. But that's kind of how we got from there to here. We've been collecting data since 2017, and I don't know what our current data count or participant record count is. John might be able to tell you that, but we've had pretty good growth. Next slide, please. So at this point, I'm going to hand off to John Picard and let him take it from there, and I'll come back and talk some more. Oh, but you're on mute.
I got to unmute. Yeah, that's a thing for me. My old director of IT bought me a mug that has one of those, you're on mute symbols. Anyway, thank you, Phil, for the introduction. Yeah, my name is John Picard, IT manager here at Faces and Voices of Recovery. I am a person who is in long-term recovery as well. So I'm not just a data geek, I'm a recovery geek too. And like Phil said, RDP 2.0 has been really advanced because of our relationships with all of our recovery organizations that utilize RDP. We have an advisory board. So a lot of the, some of the changes that we made is that first bullet where we've split up who the people that we're actually working with. The participant is that person who is engaged in recovery support services, those one-on-one services. They're performing, different assessments like the brief assessment of recovery capital. They're working a recovery management plan. They're engaged in different activities. And that family record is really interesting because now we can group together multiple records to get a total family engagement, which is something new that we rolled out. The guest record I like to refer to as somebody who's dipping their toes in the water of recovery at your organization. So they're not, they're maybe coming to the center, they're having some conversations, they might be coming to a recovery group, but they're just not ready yet. But you're able to convert that guest record, maintain all of the data that you might have collected on them thus far, and roll them into a full-fledged participant. And then we have our partner organizations, so those community members that are so important for RCCs, those referral organizations, especially to detox or to treatment or to food banks or what other community organizations that you have. Being able to have those contacts in RDP is really important. So when we get into collecting data on that participant, again, it's not just the organization. We really want to be coach focused so that the coach can have that data at their fingertips and the participant can have that data at their discretion as well. So RDP collects that basic information, demographics, contact information, phone numbers, things of that nature. But then we go a little bit further and collect those everyday kind of metrics that everybody has, housing situation, employment situation, SUD situation. And you're able to, in RDP, track and trend those changes as you work with somebody. So you're able to actually, if somebody comes into your organization and they're unhoused, you can track and trend through their engagement that you've assisted them through the referral process and got them into a recovery residence, things of that nature. So that happens through the support and service logs. Engagement is really important. That time of engagement is really important. And of course, getting into those measurements, and we really wanted to focus on not just the scores of a BARC or the scores of an engagement scale data, which I'll talk about a little bit, but really those kind of action. To me, recovery is action. I got to put one foot in front of the other, and I do that through goal setting. I do that through, if I'm working with a coach and that coach says, hey, you look like you want to do this. How about you go talk to this person and see if they can help you. So getting those referrals tracked, recovery management planning tracked is really important. And RCOs, we've gone a little bit further. Recovery community centers are not just engaged in those one-on-one peer services. They are providing a massive amount of goods to their community, from harm reduction materials to food, to clothing, to gift cards, to transportation services. So you're now able to record all of those and report out all of those. And when we talk about reporting, it's really important that you're able to show the person that you're working with inside of RDP how they've progressed in their recovery and what their data looks like, if they're interested. I mean, that's the whole thing. But you're also able to, with reporting, really get into what your data tells you and really look at individual pieces of data, filtering for what you want to see and those fields that you want to see. So really customizing and building your own reports. Next slide. So when we look at, and next click as well. So when we look at increasing those data needs, we need to streamline that capture, which we've done with RDP 2.0, made it a lot more navigatable, I think is a word. Again, choosing those special record type and requirements on those record types. So being able to customize your data the way you want it customized. And one of the things that we've added to RDP is we have set in stone assessments that are used in our, recovery community centers all across the country. However, we've given you the ability to create your own assessment. So if you want to have your own questionnaire that you're giving the people that you're working with for your own data analytics, you can do that. Next click. So then we get into, we need some mechanisms to help out, and that's through scheduling, that's through quick views, which we're going to show you, and that's through a database, a platform being responsive. So again, it all is down to flexibility for the organization and being able to really guide how you want to collect and view data. Next clicks. And improvements. So our recovery data platform is a national data set. So there are things that are set in stone, you know, race and gender. You know, we always have the other field, you know, so you can write a text box, but we want to make it so that eventually with RDP 2.0, we can really get into some deep research projects and look at recovery on a national scale and really what's going on with the recovery movement and with data and getting into some deeper analytics to get some, you know, informed systems, some information about how recovery is progressing. Yeah. Next slide. And I'll turn it over to Phil so we can talk about our recovery net.
Yep, and I'll be real quick and just hand it right back to John after this slide. But I wanted to tease, we have been working with Elevance Health, who that may not be a household name, but Anthem is who they were previously. We are developing an app by end of year it will be in the public. And I guess the best way I can describe this app is you might think LinkedIn for peer recovery, but for peer recovery specialists or people doing recovery support work specifically. So it is closely linked to RDP, and it's a location where people can do networking, continuing education. The other component of this is that they can meet with participants virtually. So there's an opportunity for people to do on-demand real-time video, so on and so forth. The benefits for providers and state agencies obviously is data aggregation and segregation in a way that even current RDP doesn't have. So I think that there's a lot coming there, and that's not what we're talking about here today, but just kind of wanted to tease that and look to see that from us in Q4 of this year. Back to you, John.
Thanks, Phil. And I did want to comment on, let's see, Virginia said, may have multiple databases to enter similar info. The stories I have heard with recovery community centers having 3 and 4 different databases because of all of the different requirements, we really want to focus on and hopefully make RDP that one database that they just need and connect to the other ones without having to do manual entry. So I just wanted to speak about that. Next slide. So this is what a participant record, somebody who is engaged in peer recovery support services at an organization, it's what it looks like when you first click on it. So as a coach, I appreciate this view because I get to know how long I've been working with this person, where they are as far as that highlights on the bottom screen, what goals they have, what domains they are working on for their recovery, what their engagement scale looks like. So the outcome rating scale, which is really about their connections to how they feel about themselves, how they feel about their connections to their family and social circle, how they feel socially, and how they feel overall. Their relationship rating scale is about how they relate to their coach, and is their coach listening to them. And then their craving rating scale is about their cravings with their substance of choice. And then just being able to look at somebody's, BARC scores, their recovery capital scale over time, taking a look really quick. And the great thing about this is if you're working with a participant, you can show your participant, the person that you're working with, this screen so they can see their own recovery capital. And of course, this is just one story. For the organization, you can aggregate all this data for everybody who is in your organization and split up based on what program, what grant funding stream you need to be able to split that up on.
Can I, John,
Yeah,
do you
go
mind if I just hop in for a second while this screen is still up? Because I mentioned before that this tool was built with individual recovery in mind, as well as collecting aggregate and big data. But different than a lot of clinical tools where you've got a clinician that is taking case notes on a participant and it's sort of segmented from the participant's view. The idea here is that there is a partnership between the peer coach. And if you think about the relationship of the peer or the recovery support professional and the individual, there's parity there. So it made sense to us that the participant would have access to be able to see this and look at their own recovery. And like, if you look at this is sample data, obviously, but if you look at the outcome rating scale, in this case, the coach might be able to use motivational interviewing to look at the first couple of pieces of data and say, okay, well, your outcome rating scale was lower. I noticed that it jumped up between our last two visits. Tell me what you did to support that. How did you go from score X to score 2X? Like, how did that happen? And allow the participant to actually process their recovery and view it in a digital way. And we think that that's a big key to both adoption and use. I noticed in the poll questions, there was a thing about, does data collection get in the way? And a big segment of the answers was if it's explained properly. And we think that having participants understand that this isn't about someone collecting data to send off to a government agency as much as it is about someone being able to track and manage their own recovery, that something about that completely changes the relationship between the recovery support professional and the participant. That's all.
Thanks, Phil. Deodora.
Perfect. Oh, sorry. Yeah, Deodora was going to alert you, John, that there was also a question from Virginia in the chat.
I do see that, and I will answer that. Absolutely.
Thanks, Deodora.
Yeah. So Virginia asked, I understand you can staff at peer recovery sports centers create tracking for outreach, networking, peer leader activities. So absolutely. Again, RDP's what we're showing here is participant focused, but there's a lot of underlying scheduling activities for participant focus. There's also ways to record group activities. So, when you talk about outreach, going into your community, being able to record some of that information. It depends on how you want to collect it, but you're absolutely able to record that type of data and track that type of data inside of RDP. Next screen. All right, so this is it's still on the participant record, and this information that you're seeing was actually closed off. So that's this is what we call a quick view. So I know when I'm working with a coach, if a coach is working with a participant, they can quickly see where the participant is with their family status. Do they have, children? Are they currently pregnant? Which you can plainly see on that status and involvement details on the family. What's their socioeconomic status? Are they housed or unhoused? Are they unemployed? Do they have any restrictions? So, how many outcomes and referrals? So they have 4 referrals that are still in progress. That's what that means. They have 5 assessments that are in progress. This person is really busy. And those would be 5 different assessments, from a brief assessment of recovery capital to engagement scale data. And then they have 1 recovery plan. So being able to have a quick view of what is currently going on with this person that I'm working with. And when I update, let's say I update their socioeconomic status to this person being employed, that check mark that you see by unemployed will go away. So that this reflects their current status of where they're at in their recovery and in their journey. Next page, please. Next slide. So now we're taking a closer look at how a BARC can really be, and every assessment reports out this way as well. It's just not the brief assessment of recovery capital. So you're able to actually look at from one to the next based on the assessment date. You can take a look going down, and then the change in that individual question from the initial until where they are at today. So being able to really take a look at, and then like Phil said, using some motivational interviewing to, possibly say, hey, what's going on with your living space? Obviously, question 7, which went negative, went from a score of a 4 to a score of a 3. So that would be something that I would raise with the person that I'm working with. Hey, what's going on with your living space? Can we look at possibly doing something? Is that a goal that we might need to set? So really digging into individual data. And of course, this is we're looking at the BARC, but this can be done on any assessment as well. And one of the things that we've really got into is scheduling. So not just peer recovery support, recovery coaching, so those sessions, but you can see up on the top where you see assessment type, and then you see frequency set. So you're able to schedule these every 30 days, every 60 days, every 90 days, whatever, 45 days. And how this works is that this will show up on the homepage of your RDP of when somebody is scheduled to do an assessment or a recovery coaching session. So we've really tried to be more coach focused, especially with respect to somebody who's engaged in recovery support services. And I think that is the last slide. You got any final words, Phil?
Yeah, I was gonna, and I typed a response in the chat about data reporting and the like. At its core, all of this is sitting in a relational database, and it's sitting, and those Salesforce is not open source. It is widely available to other types of reporting tools. Like, we did not include we had some really pretty Tableau graphics and chart infographics from one of our oldest customers, where they use Tableau to export some of the data, but the API for Salesforce will talk to just about anything. So this data is available to be sliced and diced in a number of different ways. And again, I think another thing that sometimes gets lost in this, like you can buy off the shelf software for a particular task, but we were fairly intentional in naming this as a platform, because plenty of our customers use it for one specific thing. There are some customers that use it for 10 different things. So it really is a platform for the organization to kind of build a scaffolding from. It is not just one piece of software that does one thing. And I think when we look at range of feedback from people, one of the things that comes up quite a bit is when people have a specific use for it and they know exactly what they're doing, they're typically pretty satisfied. Sometimes when there's if we're not as clear on the specific use for it, or if there's maybe not as much understanding about the breadth of it, because it's a broad platform. Sometimes there are challenges with that, but we try to we try to sort of get every organization to be able to use it. And that's it for me.
Perfect. Then I see here that we have a slide up here for everybody to click on the link to get more of a view as well. So please use it and tell us what you think. We're going to open the floor in a moment to all of you for comments, thoughts, questions. What we wanted to do first is, if you can go to the next slide, I think we have Corey here next. Excellent. So Corey, you might recall from some months ago when he did his own live feature, and he's also here to kind of kickstart our discussion about his experience with the RDP. And all of you then want to go right after Corey to kind of like share your thoughts and ideas, and we'll swap over to our discussion slides, the things that we were curious to hear from you all. So Corey, can you start us off if you're here? And
yes,
if not, perfect.
I'm happy to. I'm excited for this opportunity, and as a result of my excitement, I might have a lot to say. So I'm asking you to interject if I'm burning time. In short, like I would say, Recovery Data Platform is kind of building up out of their presentation. I am the program director for Turning Point Recovery Support Center in Massachusetts. We are state funded, and we aren't currently focused on collection of individual statistics, though we've done a little bit of that, and we will be building out into that come 2024. We'll have our participants elect to do BARC 10s on some kind of like one-on-one level. We're figuring out exactly what scales we'll be using, but I certainly anticipate the BARC 10. But currently, we use it to collect, how participants are engaging with the center. So activities, they sign up, what groups are they attending? And if they're coming by the center to use resources, drop by to meet the staff, safe, quiet space. It's really like tracking the footsteps through the door. Let's see. So like it started with, before we moved forward with RDP, we kind of test proof of concept. We created a digital sign-in with IT to see if our members would be even receptive to signing into the center. And there was not much pushback at all. And anybody that did pushback, we would just ask if they could sign in using the same name, like Yogi Bear, every time. And, we're really not going to force it on anyone, but people haven't really had much of an issue adopting it. But I met with John Picard multiple times to ask many questions. I had lots of questions. And even we met with IT to check for security, to make sure it met our security. We have like high, I can't think of the word, but like high
standards requirements.
Yes. So we met with IT, and it works with our security parameters. And what I've liked a lot of why we went with RDP is because so I'm a person in long-term recovery, and everybody that works here is, and we come to the center as staff or peers with different like life experiences and computer abilities, skill set. So it's really user-friendly. RDP provides trainings for the first 4 Wednesdays of every month at 1. So for new users, for like in the different like user levels. So they provide training, and you can always sign on to ask questions to those trainings. They also have I love RDP. I reached out to them to ask if I could support their presentation. So they have like their own, you can submit a ticket if you have a staff member that you need to remove a license from, they have an immediate response to emergent situations, but otherwise it's like Monday through Friday. They're very responsive. So they have IT kind of department out. You can submit tickets. We have a relationship with them. They're not just this place, this ephemeral, Wizard of Oz thing. And let's see, they provide infrastructure and training. There's all kinds of reporting. Geez, I have all of these notes, but you know, when you go live, you get a little stage fright. You
And
know,
that's okay. You can also come back to it, because I will say that we also have Oliver here who actually had the same thing that you had. You asked a question earlier that was already answered about reporting out. And maybe if Oliver talks, then you'll remember the points you're going to make, Corey. Would that
yes.
help?
Yes.
Perfect. Oliver, you had put in the chat here like to ask about does RDP report out to agencies like on a monthly basis. It sounds like you're using it in similar ways as Corey about checking footprints and reporting out. Can you tell us more about your experiences and what your thoughts are?
Well, I felt what so we've had RDP about 1.5 years now, I think, John. And things that I liked about it, was that it's fairly accessible. It was not difficult for me to train staff into using it, and staff to make use of the trainings. It didn't require a huge culture shift with the resistance that can come with that. So that all that stuff worked well. Staff were initially concerned for the potential of HIPAA violations, because you can see what everyone's doing with the peer. And so we do a lot of HIPAA training here, and so I had to reformulate that conversation a little bit, in that we all are the team, right? We're not separate from each other. Though if you look at mental health, electronic health record systems, they exclude everybody. So you can only make your note and not see what's the note somebody else is making. So we had to do some conversation, some conversations around that, and coming to that. I think the struggle that we had, and so, it works well enough and is easy to use enough that I'll be honest, I've become lazy as the program director. There are other electronic health records where I would have to, as the licensed person and the supervisor, I would have to sign each note. RDP does not require that of me, so people are able to work and move forward in their work with peers fairly easily. My lack of signature doesn't hold anything up, so that's a very good thing, because people are very, very busy sometimes. But we weren't getting some of the information that our funding streams were asking for. So we did, they're documenting an RDP, but we've had to set up other collection devices, to get how many in the groups, how many individual, and how many this, that, and the other thing. And with this year's funding streams coming on, they are demanding more and more information. So we were like documenting an RDP, collecting data in another electronic document. And so I have a new person coming on, and I've started to train him, and I see the new program manager's dashboard, which would have been really helpful. So what I'm going to be doing now is experimenting between what I can get out of that and how that compares with what we've been collecting anecdotally. And our next challenge will be how to document an RDP and then bill Medicaid, because we're in the process of adding a mental health license, because so many of our folks have mental health, social, emotional concerns and mental health challenges. So that's going to be our next big wrestling match. I would say overall, I investigated a number of different, data platform, and at one point I thought, well, Faces and Voices must have something, right? And that's how I met Jonathan Picard, and it in a lot of ways was the most appropriate thing for what we needed.
Awesome.
And Bettina, are we allowed to?
Yes, everybody, whenever you feel like it.
Well, and because two things come to mind right away, Oliver, and I think I want to get you in touch with. We have a number of folks that are actually processing Medicaid billing out of the data they're collecting in RDP. So that's just a kind of a direct response to that. So that's something we can work on. And I think, and again, just to directly respond to the, like, I don't like the idea of dual collection, right? That's something that wherever we go, we try and make sure that there's not that, because the likelihood of that interfering with data hygiene is a problem. So yeah, I think that there with the changes to 2.0 and possibly even maybe even through a communication thing, we might be able to help you out with some of that.
Yeah.
And then just big picture, I wanted to respond to something that was in the chat.
Was it the notes comment about the note? Did you want to repeat the question or summarize it for those who weren't reading as attentively as Phil was? If you're still here.
Sorry, sure. Thanks again for this. I really find it's such an important contribution. In our clinic, we have implemented a patient-reported outcomes measure system to collect systematic information about aspects of the recovery or mental health, and clinicians don't engage with it as much as they could. We do try to emphasize the feedback that we can provide to providers, and that has been helpful for those who do it. But there's something about identification with what their role is. Some people might say, I'm a psychologist, I'm a psychiatrist, I prescribe, I listen, I do these CBT interventions. Similarly, coaches might say, I connect with the people served in certain ways. So how do you, like Oliver has done well to engage his team, but how do you navigate this role shift?
And I can only offer what we've done that's been successful. And when I successful, what I mean by that is that we see adoption rates go up in terms of the coaches or the recovery support professionals and the amount of data coming into the system. Because I think early on we would launch RDP and then all of a sudden we wouldn't see a lot of data. One of the big differences is getting the understanding with the coaches or with the recovery support professionals that it's not that this data that we're collecting is not just about reporting, because I think that's one of the big barriers to this, is that, okay, it's just reporting. It's like a GIPRA. I got to fill out a GIPRA and I got to get it to so-and-so so I can have my money, right? And that's one, and that, don't get me wrong, as someone that's running RCO, that's very important. It's important to get your money. But RDP is a tool. And once we get over the hurdle of having the support professionals understand that this is a way for the individual to look at their recovery maybe through a different lens. And I told the story when we were doing prep for this, I'll tell it again. There's an organization, and I did not witness this firsthand. I was just told about this story. But there was an organization was working, a professional was working with a woman who had bouts of periodic homelessness, or she was unhoused periodically. And over a period of time, they'd gone through the ORS scores and the craving scores. And the ORS is it's a measure of it's an inverse measure of distress. So the higher your score, the lower your distress. But they were charting with this person, and they're showing her ORS and her craving scores over a period of time. And she noticed, they didn't notice, but she noticed that periodically her scores would dip, and immediately after that, her outcome score would dip. So her stress rating would go up, her craving rating would go up, and she pegged that to her relationship with a guy. She had a periodic on and off relationship with a guy. She could track her periods of time being unhoused directly with that. So she was able to see the relationship between those three things on an axis and see that over a period of time, the thing that was going on with her was she would get with this guy and her life would kind of fall apart. Now, upon seeing that, she sort of had this aha moment. I have no idea what's going on with her today, but at the time, the last time that I heard, she had not experienced any more of that, because what would happen after that is she would have a return to use. So understanding that RDP is that, and in addition to the other things, yes, we're collecting data. Yes, we're counting widgets, we're counting services being delivered, we're counting 15 minutes of time used in session with a recovery support professional. But having that other side of it made all the difference at this organization, because all of the coaches really started to adopt it and use it that way, if that makes sense.
That makes a lot of sense. Thank you for sharing that. I will say we are almost at the top of the hour. The good news is we still have a meeting after the meeting. We'll be stopping recording at the end of the summit at the top of the hour, but then we'll still take time to do more discussion to dive further. Olivia, can you move us to the next slide so you can kind of see the kind of questions and feedback we were hoping from, and hopefully maybe we can even get to one of them. I was hoping from feedback from the group about what you have done that was similar to Phil's story about that really made a difference for engaging people in data collection, that made it not be a barrier, but something that was useful and supported relationships. So these are sort of like our questions that we want to explore in this meeting after the meeting. And before, I know some of you will have to log because you have busy lives, and Corey, I know your hand is up too, and we'll definitely pick it up in the meeting after the meeting. Next slide, though, I just wanted to remind you all of our upcoming seminars. So one of them is going to be coming up really soon, because as you all know, today's seminar was off of our regular first Friday of the month schedule. So here are our two next ones. The next two presentations are the results from the pilot studies that have been funded by our program in the past that now are able to report back to us what the results are. So if you haven't already, please go ahead and register, and we look forward to seeing you there. And then this was our last slide, Olivia. I'm not forgetting something important, am I? Excellent. So we are good. So I just wanted to, if you swap us back over to the discussion slides, I want to thank you all. And then Corey, I want you to go ahead with your question or comment rather.
Okay, perfect. I feel like I took notes here. So just to wrap up my points, and then we'll, so what are some of the questions I asked? We were able to make sure that RDP collects the data that is required for the state. So we collect it there, and then we input it into the other system, that was really important. It's reasonably priced, and it's also half priced for members of ARCO. So, that was one of the other pluses. And it also, say John found a pot of gold and decided to retire, RDP will not shutter its doors. That was a really important part of why we went with RDP. So, longevity. So then the segue into the discussion, so I'm a person in long-term recovery, and, therapy, I still have, a clinician, and I would elect to fill out the surveys. I don't know what they're called, and maybe they were supposed to be quarterly, maybe they were, every 6 months, but I would fill them out and we would go over them. And over the years, I could see she would show me where my scores fluctuated. And that was really important to me, to see my progress, and also where more progress could be made. Those were really clinical kinds of surveys, but not all peers coming to the center have clinicians, and even those that don't get to see their data. So I love that we can sit down with someone. It's not about charts and graphs. It is about qualifying how you're doing. It's not just about not drinking a day at a time. That's very important, but it's your recovery is happening in so many ways and you might not even know it. So we get to show you the improvements and the progress, and then you can identify areas of, to celebrate and to grow. It's to help it be more self-guided by our participants than what we say you need to do. So that was kind of my last point to segue into the discussion.
Perfect. Thank you, Corey. And we can end the recording now so we can all just kind of discuss more freely. Thank you all for being here.